All right. So we have the next segment is actually doing a little bit of a drill down and nuts and bolts on a couple of these quality measures to help understand what goes into the numerator and denominator and how you can actually improve your quality and compensation in these new contracts. We have a dream team that includes Claire Boogaard and Ed Fox, who are medical directors for our Pediatric Health Network, and Charlotte Harper and Erica Weiner, who are key members of our staff in terms of looking at the data and helping practices get it done. So I'm just going to step aside and let this dream team get rolling.
Thank you, Dr. Weissman. So yes, Erica and I are here to talk about how to, oh goodness gracious, excuse me, how to succeed in value-based care. We are, Doctors Boogaard and Fox are here mostly for moral support, but here to answer any questions. So as we heard in the previous lecture, value equals quality over cost. In value-based care contracts, quality is measure performance, such as the HEDIS measures that were discussed. Erica and I, are going to take a deep dive into what quality actually means in practice. Measures, there are measures in every contract. For each measure, the PHN and the payer get together to establish 3 or 4 tiers or targets. This is an example of a contract benchmarks. The PHN also, and PHN and payers together, excuse me, also set a points available for each measure. So the better the performance, the more points you get. For example, if we had measure A and our tier 4 performance goal were 25% and our tier 1 performance goal were 50% and our CIN's performance on that measure were 25%, then we would get, in this example, 50% of the points available, or, and I'm a math genius, you guys, it is 10 points. So in that example, and again, this is just an example, we would get 10 points towards our contract. PHN is required to meet certain thresholds for the points in order to be eligible for shared savings in every contract. Erica and I are going to take a deep dive into 4 different measures today listed up here. We're going to talk about the definition, numerator, denominator for these measures. We're going to talk about the codes that are applicable. And we're going to talk about strategies. The strategies that will be discussed today are examples. They are by no means exhaustive for strategies to improve on these measures. And then we will also touch on next steps for these measures, because as we all know, these are all a work in progress. The work is never done and things are always changing. So yay. So I'm going to turn it over to Erica for our first measure.
Okay, we are going to start out with depression screening and follow-up for adolescents and adults. This measure definition is percentage of members 12 and older who are screened for clinical depression using a standardized tool during the measurement year, and if they screen positive, receive follow-up care within 30 days. This measure is in our Care First contract, and the payer instructions to capture these screenings is to use either the LOINC code for the tool that's being used and a screening score in order to identify positive versus negative results, or to use G codes, G8431 for a positive result, G8510 for a negative result. PHN focus on this measure is to determine EMR workflows to implement this coding. This screening for this age group is, of course, not any type of new practice. The screening is already being done for patients in this age group, but the LOINC and G codes were new for almost every practice in our network. And just to share the specific codes for this measure, again, the G codes for positive and negative, and the LOINC codes for the different accepted depression screening tools and the threshold for a positive result. Most of the practices in our network use the PHQ-9 in their clinics.
So some strategies to really conquer this measure. As Erica mentioned, our focus at PHN was to optimize your EMR. Now, all of us are on different EMRs, of course, but to optimize the EMR to work in your favor and to maybe adjust a workflow. As Claire discussed this hierarchy of intervention effectiveness, the system-focused, more effective strategy would be to attach the LOINC codes to the appropriate screening tool on the back end of your EMR, obviously avoiding any interference with the provider workflow in the office. The people-focused would be to add both G codes, to the visit template and have the provider either remove one or, if you just added the negative to the visit template, having the provider workflow to adjust it to the positive G code. Now, G codes in and of themselves could be system-focused interventions. In this case, however, we are asking, a person to remember to do something. Not everybody has the capacity in a 15-minute visit to get that done. So we do advocate for system-focused interventions. Yes, happy to. Oh, hold on 1 second for a microphone. We want to get this. Okay.
So we know that. And we also know that depending on your practice and your practice type, some are able to send it without a charge just to get credit for the value-based care and some are not. And on top of that, some EMRs, I'm not sure which one you guys use, don't make this easy. So what we're trying to do is give you as many options as possible. You have LOINC and or G codes you can use for this measure. But if we're going to get to this in a second. If you guys have any ideas on this measure in particular, because this is one we're monitoring closely given the focus on mental health, come talk to us. The G LOINC code conversation, every time we think we've nailed it in our head, gets changed. So please just, great question. We totally hear it. I'm not sure we have the right answer for you, and I'm not sure it's going to be a universal answer, but happy to talk to you offline about it.
Also, just to spotlight, this measure is going to be the focus of our QI initiative this year, and we plan on organizing a lot of EMR work groups to help other people on your EMR who perhaps maybe have mastered this a little bit more.
Okay, and looking at improvement for this year on this measure, we have our baseline data, which is from August of 2021. We were showing a performance here of 0.04%. And again, this is just the screenings that were being captured. So just really highlighting again that this coding was new. It was not being used at all. And we had incredible improvement this year. We are at 17.62% in our November scorecard from Care First, which has claims and EMR data through September. So the target for this is set around the 10% range by the payers. And we are now scoring, we're getting points for this, which is amazing. And payer did share with us that we are, so to speak, ahead of the game, doing really well in this measure capturing, and it will probably even bump a little bit more as we get data for the last 3 months of 2022. And looking at use of G codes for 2021, about 4% of our practice locations in the network were using G codes. And in 2022, we had almost half of our practice locations use the G codes for the depression screening measure. So that was really great that so many practices have been able to use those. But again, as Charlotte and Dr. Boogaard said, it really will be different for every practice. And looking forward at future work for this measure, we will continue to work with Arcadia, with our EMR vendors and our practices to make sure that G and LOINC codes are captured. We want to automate whatever we can, make it as easy as possible for providers and come up with different workflows so our practices have options to implement what works best for them. And in 2023, we will also be partnering with our payers and practices on workflows and coding to capture 30-day follow-up of positive screenings. And as Charlotte said, this measure, especially focusing on the follow-up, will be the topic for our 2023 MOC eligible initiative. And moving into childhood immunization status, Combo 10 measure. This measure is percentage of children 2 years of age. So this is members who are turning 2 during the measurement year who had all of these childhood vaccines by their 2nd birthday. I'm not going to go through all of those. What we are going to be focusing on is the series of 3 Hep B vaccines by 2nd birthday. This measure is in our Care First contract, and PHN focus is on capturing the first dose of Hep B, the one that is given in the hospital at birth. This has been a long-standing issue to capture this dose of Hep B because it is bundled in the parent claim.
So yes, that was our challenge, was to capture that first dose. It's something we're obviously working on an ongoing basis. PHN was able to partner with Care First and advocate for them to set up state immunization registries. A data feed from state immunization registries. Thus far, they've started pulling data from Maryland and Virginia. We hope that they continue to expand and that we can continue to expand this practice to other payers. That is our system level all around good intervention for this particular dose. One thing that we need practices to do is to manually input the first dose of the Hep B vaccine into the immunization section of the EMR. We have found that sometimes they can be in notes, of course. They can be just in places that payers are not looking for them. And also our data management system is not looking for them there. So we do advocate putting them into the immunization section of the EMR.
Great. And looking at improvement on this measure and also at the Hep B series in particular, looking again at baseline data versus our recent scorecard with claims and some EMR data through September, we went on the overall Combo 10 from 14.69% to 39.21%, which is really great. And for Hep B, we went from 19.6 to almost 50%. And this is, again, with some state registry data that they've set up, getting feeds from, and some EMR data. And looking forward on this measure, the payer is actually working on setting up monthly data feeds from additional state registries to capture as much as that immunization data as possible. And we anticipate continued improvement over the next few years on this measure. The denominator is patients that are turning 2 during the measurement year. So as we are setting up more data feeds to get this first dose of Hep B, when it is given or when it is first documented, we will see that reflected as these patients turn 2 and are included in the measure. And there's also a hexavalent vaccine, Vaxelis, that several practices in our network have either started using or are going to start using. And this will also help. It is given at 2, 4, and 6 months and has Hep B in that vaccine, even if it's given at birth. So even if that birth dose is not captured in any of the feeds that are set up, the patient will still have 3 claims with a Hep B vaccine. Okay, and looking at our other immunization measure, immunizations for adolescents, this is Combo 2. This measure definition is adolescents 13 years of age who have had 1 dose of meningitis vaccine, 1 Tdap, and completed the HPV series by their 13th birthday. This measure is in our Care First and HSCSN, which is a DC Medicaid plan, contracts. And PHN focus for this measure is on timely completion of the HPV series. The HPV vaccine in this measure is, of course, the challenge and really the key for success here.
Yes, so in our adolescent QI project this year that was available to PHN practices, we really focused on starting this vaccine series earlier than the 11-year-old well visit. We have found that not only is starting earlier good for measure performance, it actually is better for patient care. The immune response of younger patients is in fact better than in slightly older patients. So not only for the measure, but clinically, it's a good idea to start early. One way that practices implemented that was to add the HPV order to all well child visits for 9 and up. Whether or not the first dose is given at 9, starting that conversation earlier has found to be an effective way to finish the series before 13. The people-focused intervention is an important support for the overall intervention of starting early, educating your providers and, very importantly, your frontline staff on the importance of the vaccine, the effectiveness of giving it earlier. Educating staff and providers is incredibly important to support this starting early move. A lot of practices have utilized the pharmaceutical representative in giving that education to their providers.
And looking at our improvement for this year on this measure, we did see some improvement for the combo 2 measure, going from 45.85 to 48.89%, putting us into tier 1 and getting full points for the measure, which is amazing. And we see very similar improvement reflected for the HPV series. This one, similarly to the combo 10 childhood measure, we will continue to see improvement over the next few years. The denominator for the measure is patients who are turning 13 during the measurement year. So as the vaccine is given earlier and 9, 10, 11-year-olds are getting and completing the HPV series, we will see that reflected as those patients turn 13 and are included in the measure. And as Charlotte said, we are looking at an ongoing QI initiative around HPV vaccine uptake for practices who did the adolescent initiative and are interested in continuing that work. Okay, and the last measure we're going to talk about is the weight assessment and counseling for nutrition and physical activity for children and adolescents. This measure definition is percentage of children and adolescents 3 to 17 years old who had an outpatient visit with a PCP during the measurement year with evidence of BMI percentile, counseling for nutrition, and counseling for physical activity. This is in our Care First and our HSCSN contracts, and our focus at PHN has been on determining streamlined EMR processes to include the required coding for this measure. This has definitely been a work in progress through the year, especially with different EMRs. There have been some challenges with including the extra coding in the billing section or in templates in the EMR. So definitely ongoing work around this measure. And just to share, and just to share the codes for this measure, there are some CPT and ICD-10 codes for both nutrition counseling and physical activity counseling.
Yes, and as Erica said, it is a work in progress. PHN's focus was on coding. We started off advocating adding the Z codes to templates for well child visits for ages 3 to 17. Don't get me wrong, we are still advocating that. However, we did hear from a couple of practices. They contacted PHN and said, hey, wait a minute, this other payer has asked me for a different set of codes. What am I supposed to do? And we appreciate that feedback so much. So we were able to take that information to the payers in our VBC contracts, confirm that they are accepting those codes as well. We took that information to our data management system and confirmed that they are mapping that data as well, mapping those codes as well, excuse me. So we need your help. You know, PHN is a convener of people and we are an advocate as well. So we try to hear everything and report back to payers. So we appreciate those practices who give us those little tidbits. We appreciate all the other practices as well, just FYI. People-focused intervention is education on the clinical requirements for this measure. There seem to be many, and the coding requirements seem to be fluid. Let's just call it that. So again, education is a great first step. The system-focused interventions are a great way to solidify the practice.
And looking at improvement on this measure for 2022, we have nutrition counseling at the top of the graph and then physical activity counseling. So we did see some improvement on both of those measures, which is great. We started really focusing on this a few months into the year. And as we've said, it's definitely a work in progress to really find the best way to do this in the different EMRs across our network. We're always looking for the most streamlined, most automated way to do things. So if this is something your practice has been focusing on, or if you had some issue in your EMR you were able to successfully troubleshoot and you want to share that with other practices, we would love to hear from you and work with you on that. So please reach out. And looking forward at continued work on this measure, the best way to improve performance here is, of course, going to be continuing work to increase well visits. It's really where this counseling is going to happen. So we just finished a pilot with the Arcadia outreach functionality for well visits. So we will be continuing doing another pilot, and we will be offering that to practices in the network if they are interested in using Arcadia for that. And we also have well visit gaps reports that we can set to trailing year to identify patients with no well visit in the last 12 months. And we will also be exploring if it's feasible at all to expand this nutrition and physical activity counseling to visits besides well visits. The denominator for the measure is actually patients with any PCP visit during the year, even if it's not a well visit. But we, of course, know doing this counseling at all sick visits is, not going to be feasible. So just something we will be looking at.
So that's the big idea. Any questions? Yes.
But if there's actually a concern or a diagnosis of a mental health issue, I'm not sure how to get that covered by particularly the Medicaid, straight Medicaid and the MCOs.
Do I want to repeat the question? No.
The question was about being reimbursed for coding follow-up visits for mental health
With a diagnosis.
with a diagnosis of mental health with Medicaid plans.
Here,
I'll
jump in here. Is your concern that it's hard to label it as a mental health diagnosis or to get the credit for the follow-up, or both? Yeah.
More so I don't care necessarily. Well, I do care about the credit, but to be reimbursed if the only reason that I'm seeing this child is for that mental health concern.
You know what? That's a beautiful question. I had that myself as a pediatrician because I think sometimes we know we're not the right provider for that patient, right? And so you don't want to inconvenience them further or force them to do something just to get a check on the box. Dr. Lee Beers is our behavioral health initiative medical director for the Pediatric Health Network, and is actually going to do a multi-year funded plan around this. But what I can tell you from the brief answer to that is some good news. It doesn't have to be with you. The follow-up code can be from a mental health provider if you can find one in 30 days. It can also be for, anyone in your office that can bill an in-person or telemedicine visit. And what the good news is that we just heard from our payer, I'm glad I get to spoil this, is that if you make a telephone call with an ICD-10 code that explains a diagnosis related to mental health within the 30 days, that counts. So even though you're not billing for it, as long as that diagnosis code is somehow attached to your EMR's telephone encounter, you will get credit. So this is one that on our contracts, at least through the Pediatric Health Network, we're monitoring this year. So we're not getting measured on, our savings are not determined by it. But we have two separate initiatives that are going to look at it pretty in detail. And so we hope to just keep giving you more and more feedback. I think my big takeaway from my role so far in PHN and learning this, the ins and outs of this, I figured someone knew. The payer knew, the insurance company knew. Someone was just we just needed to gather all the information. We'd be able to feed it right back to you. Oh, hey, this is the codes that are needed. Really straightforward. Let's just try to make your workflow work. I am really surprised that that's not that simple. The payers don't necessarily tell you what codes they need or have. You might have to pay for certain codes. And then on top of it, you go to the 5 different EMRs we have in the network, plus there are many other non-network providers here. And you have to work with your individual EMR to make that easy to implement. And so welcome to the fun of quality improvement work. But I just figured there was an answer, but honestly, it's not that clear. So as Mark always says, this is a work in progress. And so we are hoping to give you those answers so you personally don't have to be like in the weeds with it. So that's why we are grateful when you guys give us feedback, but also really reliant on which problems you're coming up with G codes and which system you have and which district you work in, which state you work with, that kind of thing. So we appreciate all comments and questions.
How can you attribute patients who, because I have few patients who refuse vaccinations at all. So we don't have any control. So I just let them sign on the AAP refusal to vaccinate form. No matter how much I convince them, they still strongly refuse.
We've had this question a few times. Unfortunately, vaccine refusal is not an exception from any of the vaccine measures. So those patients are still included, but it is the reason our targets are not set at 100% for any of these measures, because we know there always will be patients who are refusing to vaccinate or for some other reason aren't going to meet the measure. But that, yeah, unfortunately does not exclude them from the measure.
But there is also an ICD-10 code that says, for vaccine refusal, which will appear on the super bill. Some families may not like seeing that, but it also sends a claims message that you did your job, sort of recommending it and trying to do that. To Erica's point, the numerator and denominators may not change, but I think the most important take home from this conversation is no one has it all figured out yet. And quite frankly, when we knock on the payers' doors, they're like, we'll get back to you. So what are they telling you? Actually, they're not even sure of their own metrics that are sort of built into some of the contracts. And I think part of the value of beginning to get practices cohorted and sharing information, this is what works and this is what doesn't work. You're still chasing your claims and those sorts of things at the practice level. But if this data is now fueling additional quality performance and compensation to your practices, we darn well want you to be successful. So I think that's part of learning. We won't have all the answers today. Part of that is because we are asking our champion practices, and sometimes they're like, and then we're knocking on the payer's door and trying to get clarity. We have about 2 or 3 minutes, and then we've got to move on.
Question. Really quick. We've recently acquired a lot of patients from an office that closed, and a lot of the patients did not need annual visits, but they need to be seen to establish with our office. So we were trying to figure out the best way to code the visits, because there technically is not a code for just seeing the patient to establish the care, because it's no reimbursement really for that.
I can tell you from all the whispering on stage, we're going to have to get back to you on that.
Thank you.
No.
Is there anyone in the audience who has dealt with that successfully? Rachel, others?
The AAP has a coding hotline. The AAP has a coding hotline that you can email, and they'll give you the guidance on how to code those.
They have something. I mean, honestly, if I look in a nose, I see nasal congestion almost 100% of the time. So I might put that in there. Yeah.
I'm just going to add the one other point that on these contracts, they might not actually be attributed to you until they have a well visit. So that's a whole added element. Anyway, that would be very interesting since there's such a discrete change. I wonder if we could help advocate for your practice if there was a thing that we could do. So keep us posted, but it's tricky.
As a provider, I've also been guilty of looking at the parent and be like, give me something. Any concern you had before coming in here today? How did breakfast go? Yeah.
Just one more comment for Dr. Madden asked. On the G code and billing for it with the zero charge. I actually learned at another conference this year that some of those G codes are paid by some Medicaid plans, not in Maryland, where I am or where a lot of us are at the moment. So unfortunately, probably not here, but just keep that in mind when you apply zero charges to things that might be coming down the pass at some point. Florida, I know for sure reimburses the G codes a little bit. And you can get away with it by putting like a $1 value on the code to get it to go through clean and then just writing it off on the back end.
The other thing
Or
is, I think
penny,
people
whatever,
wish G codes
like
were
round numbers.
disappearing. But it seems like if anything, the social determinants of health screen is going to start using G codes. So I don't think G codes are going anywhere. And we just had a meeting with Office Practicum this week. Hopefully that's not breaking any rules to tell you this, but they also they hear loud and clear that they're here and they're here to stay and they need to make them easier for you guys to use. So we'll keep pushing it.
This is a work in progress for all of us. If you have questions, corner these folks out there at lunchtime or whatever, and we'll keep working to sort of exchange knowledge and success back and forth. And we'll do it that way. And it's a work in progress. So thanks, team.